L'éradication de la poliomyélite à l'épreuve des faits.
Eradication of polio. Why did MSF decide to organize such a discussion on a global public health issue that is not recent? Because for 25 years, the Global Health Assembly has decided to eradicate polio, that is, to eliminate it, to reduce transmission of the virus, to take it down to zero. So the first answer is that it is not a recent struggle, and we thought that we had won this at the beginning of the 21st century, and there was a resolution saying that polio eradication would be a gift from the 20th to the 21st century. And there were dramatic results during the first 12 years of the polio eradication campaign, because we went from 350,000 cases yearly to several hundreds or several thousands of cases at the beginning of the 2000s. But now, for the past 15 years, polio eradication has been a struggle that has never managed to come to an end, and there are more and more difficulties on the way to eradication and on the way to the last mile, which is supposed to take us to the final objective. So that's one thing. And something else is that the MSF teams are directly involved in events connected to this eradication campaign. In 2010, and you will have some documents in this folder that's been given to you, MSF teams have had to face a very deathly polio epidemics in Congo-Brazzaville. There were some 500 cases of acute flaccid paralysis that were reported, and I think that more than 180 died. And MSF had to take care of the people who had who got the polio. So we had to manage that. And more recently, in Pakistan mostly, but also in Nigeria, our teams have witnessed a very tragic phenomenon, which is an epidemic of murders of polio vaccinators. Because since the month of January in Nigeria and in Pakistan, there have been more than 30 Nigerian and Pakistani vaccinators who have been murdered, more or less directly, while they were administering the oral vaccine in some areas in those two countries. So that's for the reason why we're here. Now, the purpose of this discussion is going to be to look at the polio eradication campaign in conjunction with facts. The facts, as presented by the campaign coordinators, are a lot of roadblocks on the road to eradication. First of all, we have reinfection occurring in some countries. We thought that the virus had been eliminated from those countries for a certain number of years. And also since the beginning of the 2000s, we have seen epidemics, which are the poliovirus epidemics. But this poliovirus actually derives from the vaccine, and sir, you will help us understand this. And then there is the persistence or arrival of resistance areas in some countries, not only Pakistan and Nigeria, and also, as I said, there is also this new phenomenon which must really make us think about this, which is the murder of some polio vaccinators. Now, in order to look at all this, we have invited a certain number of people who will help us view this from the medical angle, from the social science angle, in order to try and understand what could be summarized as a discipline issue. Because diseases and human beings do not behave as planned. So the idea is to examine the facts for what they are And also, of course, these facts, these difficulties are certainly not new for the coordinators in charge of the polio eradication campaign, and they have been their concern for a certain number of years now. So during this discussion, we don't want to think about the best technical way to overcome these difficulties in order to reach the eradication objective, but I think what we should do would be to try to talk genuinely about the human, social, financial cost associated to those measures aiming at overcoming these difficulties. Because then the question is, how justified is it to maintain this eradication objective given this cost, this burden which is associated to it, and given all the negative impact that we know of? And this is what we're going to talk about today. I'm going to introduce the discussion as such. Dr. Jafari to my left and Johannes Everts. They both represent WHO. Dr. Jafari, I can say, is one of the architects of the eradication of the polio virus in India. And he now leads the polio eradication campaign at WHO. And Johannes Everts used to be a colleague of us at MSF, and he's a technical expert now at WHO, and we will be able to shed some light on some technical issues. Dr. Elisha Renne is an anthropologist in the University of Michigan. Just flew in this morning, so I really want to thank her for being here, and she wrote a book which I really recommend you to read, which is called The Politics of Polio in Northern Nigeria. And she's going to tell us about the challenges in the eradication campaign in the north of Nigeria. We also have live from Karachi, and we are going to start with him for time reasons. Dr. Jooma is with us from Karachi. He's the former director of health, and now he's a researcher and a professor in the Aga Khan University. And we also have Laurence Lurie, who is who is in charge of MSF France emergency programs, and Florence Fermont, who is the vaccine specialist, vaccine expert for MSF France. And then also on Skype from Islamabad, we have our team of MSF there. I'm sure all of them are there. They're going to listen to the discussion. And I would like to welcome also Heidi Larson, a colleague of Heidi Larson, sorry, who is a very famous researcher working on confidence and trust in vaccination. And the colleague's name is William Schultz. He's here with us, coming from London to attend the discussion. So thank you for being here.
Pakistan continues to be a challenge as far as polio eradication is concerned. But in common with the other endemic countries, its efforts are hampered by a war situation on the ground. And that really makes running a large public health programs very, very difficult and challenging. I'm also pleased to see that MSF has put itself out there to be considered as a possible partner player in the effort, because I've had the opportunity to work with MSF in the floods in Pakistan, and they have a very good track record of implementation in difficult ground situations. And quite frankly, that's what we're faced with in polio. And so I'm sure that Hamid will agree with me. Their involvement with social mobilization, their involvement with trying to correct the bad perceptions about polio eradication that have gained currency in our country is something that we should all welcome. Pakistan's, if you look at Pakistan's polio incidences over the last few years, there's some things that should give us great comfort. We have seen that early on the P1 virus was really what had taken hold in our hinterland, but the P2 virus was eliminated about 3 or 4 years ago. Pakistan was seen as the last major reservoir of the P3 virus, and we hope that with a year clear behind us, we may also have eliminated the P3 virus from the field. So this is something that is a tremendous step forward. And if you look at the outbreaks, it is getting more and more restricted. It's getting more and more restricted to the border areas between Afghanistan and Pakistan. A couple of years ago, there was 3 or 4 districts in Balochistan which were seen to be very intractable and very difficult. And I think we need to congratulate the Polio Eradication Initiative folks that they have been able to overcome the difficulties in Balochistan, and Balochistan so far this year is polio free. So the real difficulty that they're faced with, and we recognize that this is a great challenge, is how do you get to children in a war zone, particularly when the population is not well inclined to international public health efforts and vaccination campaigns. And I personally feel that we should continue to work in those areas as we have, but even more important, we need to try and build and construct a firewall of immunity around our tribal areas and the KPK province, so that the districts that have become polio free in the last few years remain so. If you look at the outbreaks, they're almost all connect across the country. This is outside the tribal areas. For instance, in Karachi, where 3 districts have shown activity, not just in patients, but also in the environmental samples, in the sewage samples, so that polio virus is to be found in the sewage. If you look at the areas in Karachi, these are areas where population movements are directly linked between the tribal areas and Karachi, even though they're separated by 1,200 or 1,500 kilometers. So we really need to continue to work towards high quality campaigns, but more important, focusing our efforts to a greater extent on routine immunization. In the introduction, you heard that we've been doing some research in polio. Well, really, the thrust of our effort is that we need to improve routine immunization in Pakistan, and if we are going to be using the resources of polio eradication, this would be a good thing, so that the polio eradication community needs to see the problem not just from the lens of polio eradication, but it needs to see this in the larger context of immunization. And I'm pleased that the current management of our expanded program for immunization has this on their agenda and has this in their sights. But I think that this is something that we need to be concentrating on. The other thing that has been on the cards for a very long time, as all of you know, polio is a highly contagious virus. Indeed, if you look at what's been happening around the world this year, most of the cases that have actually come to light are those that have been imported into non-endemic countries. So it travels easily, it's highly contagious, and there is very serious thought being given countries like Afghanistan, Pakistan should have travel restrictions placed on them to try and protect other populations. I think that that is something that perhaps can remain on the agenda, but that concept we should apply to the areas of polio virus circulation in the tribal areas and in the KPK province of Pakistan. We need to make sure that all transit points, we need to make sure that all population movements are covered by our eradication effort. My concept of the firewall of immunity basically brings the idea of controlling polio virus circulation by controlling the non-immunized individuals' movements from one part of the country to the other. I think that this is an extremely difficult task. The targets that the WHO and the Polio Eradication Initiative had set itself have been revised at least 3 times since the time that they were first set some 10 years ago. And that is because we did not anticipate this war situation. So I think that perhaps we're in a situation where it may not be realistic to set ourselves a target like 2015, but if you look at the way polio virus circulation is running down in areas that are non-war affected, this gives us cause for hope. And if we keep at it, there is no reason that when the time comes for us to gain access to all those unimmunized children, we should be able to stop this virus dead in its tracks. I thank you.
Well, our friend had time constraints, so I turn to Laurent now. A point that was not mentioned by Dr. Jooma among the challenges related to the eradication of polio, this big objective. What about those murders of vaccinators? MSF people being the indirect witnesses to that. Laurent Suré. Yes, it brings us back to the question that brings us here today. With Dr. Mathis Berthelot, I've been following Pakistan, and since 2012, we've seen a real outbreak of murders of vaccinators. We reviewed the media to see how they addressed the issue, and we realized soon there was sort of an official message picking up various elements about immunization in Pakistan, countries where polio is endemic. So there was a media focus in December on the matter. Many papers came out in the press, in the media, lots of interviews, and we realized that the way those problems revolving around polio eradication were addressed, they were all addressed in a very similar and stereotyped way. As a medical organization in Pakistan, we had to take a stand, communication-wise, but apart from saying that we're quite sorry to see health workers being murdered, and apart from restating that we had to protect health workers, which is only a conventional message, after all, well, I felt extremely frustrated because all the explanations, analysis, the papers I read, the articles didn't contribute anything to shed the matter on the why behind those murders. At the end of the day, the message was rather polio eradication efforts will have to continue and will continue, and people will have to adjust to it. We had very few data elements explaining why we had reached such a situation with homicides, and nobody dared question a strategy which began to be accompanied by many casualties. So the crash at MSF was already working on the matter in Nigeria. We started discussing it with Florence, and from the operational standpoint, we had some big questions raising. Medically speaking, we do not participate in polio eradication efforts in Pakistan, whereas we do it in other countries. But it's because we know that in Pakistan, our teams would be exposed to dangers. So for operational and safety reasons, we deem it's impossible for us to take part in that campaign. However, we do provide routine immunization. So the questions that came to me as we were working on polio eradication and how it was dealt with in the media and how things were progressing or not in Pakistan. Well, since December, more polio vaccinators were murdered, so it's still a very topical issue. So a very fundamental question I had was, how far shall we have to go in terms of human cost, in terms of the number of vaccinators being killed, for the polio eradication strategy to be at least discussed again? Maybe not totally revised or revamped, but at least rediscussed and reviewed. Because in all the papers I read, nowhere did I see a challenging of that strategy. The main message was we have to continue targeting this objective of polio eradication. So just looking at the number of polio vaccinators killed versus the number of polio cases, we have to ask ourselves the questions. More than 20 vaccinators have been killed. So how far do we have to go in that series of murders for us to really stop and think and review whether this strategy is actually effective? And then, and this doesn't happen only in Pakistan, but also in other countries, each time some polio days are organized, you have a big wave of mobilization impacting all our medical activities. Our staff members take part in the eradication campaigns. So it creates a general, pretty intense mobilization, yielding impressive results, as Claire said. If you look at the numbers and the reduction in the number of cases. But in the areas where we work, usually there is no health structure around. Hence, the difficulties for the patients to get their children treated for common diseases because there is no health system or they cannot access them. So they're deprived of basic health care. And in contrast, there is a huge wave of mobilization, canvassing door to door for polio eradication, a huge medical mobilization against a disease which, thanks to the past efforts, a disease which is not a current, topical, urgent health issue among those populations. So I was trying to understand all that, and I do understand why the local populations would look at all this with some suspicion. When the basic medical needs are not met in a daily basis, seeing all that flurry for a pretty rare disease, after all now, a disease which is no longer a health priority. I do understand why people would be reluctant and would look at all this with a degree of suspicion. And also, well, we try to make the link between the huge needs allocated to polio vaccination and, on the other hand, the huge local needs. How could we couple all those resources and means deployed with other general health measurements, such as routine immunization campaigns, which is important? The question is, how could we increase the healthcare offer, including vaccination, while reducing the degree of suspicion vis-à-vis polio vaccination? So we operational people and Jean-Guy, the head of mission in Pakistan, were sharing all those concerns, and that's why we turned to CRASH as a think tank to deepen the discussion together. The key point for me is that we feel it's high time to raise the question, to put it on the table. when we look at the total absence of discussion or analysis over what's happening with the killings of vaccinators, polio vaccinators, we do feel, again, it's high time to raise the question because it's never touched upon, nowhere in the press, in the media, not a word about that. So we do have some proposals to put forth. We don't mean to totally question or challenge the sound basis for the will to eradicate polio. We just want to discuss how we go about it and maybe make our dissident voice be heard in the midst of that big official and repetitive and exclusive discourse. Claire Magone. Thank you, Laurent, for underscoring what the designers of the campaign sometimes recognize as excessive optimism in the way they describe the achievements of the campaign. Now, regarding this clash you mentioned between priorities and what the local populations experience in light of this, and the shortages in basic public health they have, I think we'll go back to that with Elisha. And the case of Nigeria, there is another concern. It's about the security and safety of polio vaccinators. You know, the Pakistani authorities do a lot to try and protect them, but there's been an escalation, by the way, in the coercive measures trying to impose the vaccination campaign while trying to protect the vaccinators. Tell us more about this, Laurent. Laurent. Well, it's a bit the same questions we have about the human cost and the number of casualties. At what cost are we ready to pay the eradication of polio? As long as we have to protect health workers with men in arms, then for us, definitely there is a problem, and we have to analyze the situation in depth because it is problematic. The tendency, as you said, is now to protect those vaccinators so as to continue with that strategy. In Pakistan, the problem with armed escorts, beyond the mere question of protecting health workers with armed men, is that the war situation or internal conflict situation in Pakistan is such that the security forces and the military are also a target for the various armed groups. We've seen in Pakistan, and that's connected with the human cost, this escalation in protection, armed protection, to counter population resistance and the targeting by the armed groups of these polio vaccinators. Claire, thank you, Laurent. Yeah, just for information, the polio vaccinators in Pakistan were first authorized to carry weapons themselves, and then some policemen were supposed to escort them. I don't know where it stands today, but they're discussing having a full-fledged military force accompanying the vaccinators. It does raise the question, you know, how coercive do we want to be? And in parallel, to wind up on this, you were talking about the way the press, the media dealt with the matter. What struck us, seeing the way the press and the media reported on that, was that there is a sort of martyrology, a worshipping of martyr around the murders of vaccinators, who sometimes are presented as sacrificial creatures. Not long ago, a Pakistani newspaper's title was "The Angels of Karachi," and this woman was saying, "We all gonna, you heard that, we all gonna die of something one day. Why not die as a brave hero?" Which translates a deliberate will to have a whole staging and make it dramatic, this death of polio vaccinators, and use it and to display it as a useful sacrifice for the community. Well, you were saying we don't question or challenge totally the reasons for that objective, but I think we can go as far as questioning the very objective of the GPI while noting the spectacular strides we've made over the last years. Let's go on with Dr. Jafari.
Maybe make a presentation on the historical background of eradication and the challenges seen from your lens.
You'll have to put up with my English, unfortunately. But first, I want to thank MSF for inviting us to this very important discussion. And MSF is a very, very important partner for WHO. And as you all well know, and as some of the maps I will show you will clarify to you how important MSF's involvement and engagement is to the success of polio eradication. So we consider MSF a very crucial partner in the polio eradication effort. And this particular topic that you are discussing today is clearly one that is a major challenge for the program. And so I think the outcome of this discussion is going to be very important, as we are also, of course, thinking about and engaging and consulting a wide range of experts in this regard, because clearly the challenges in the program are no longer technical or programmatic or even operational. They are now mostly social and political. And it's in that context that this discussion is very, very important. So I think we really look forward to a rich discussion. I just wanted to show you that the new strategic plan for global polio eradication has 4 major objectives. This goes from 2013 to 2018. The first objective is the detection and interruption of transmission of polio virus. And that's what really is the bulk of the eradication effort, and most of our discussion and presentation will be focused on this. But I do want to highlight that the second objective is the one that I think people have referred to, which is the linkage between polio eradication and strengthening of routine immunization, particularly in the most difficult areas where routine immunization of children is very much challenged and difficult to achieve. And then there are, I want to point the fourth objective, which is to undertake a long-term legacy planning, which relates to what are the longer-term, broader benefits from the lessons learned from polio eradication to other public health programs. So these are the objectives of the strategic plan. Most of my presentation will deal with the first objective, which is interruption of polio transmission. So this is what the world looked like in 1988. When the World Health Assembly resolved to eradicate polio, 125 countries were reporting polio, and an estimated 350,000 cases of polio were being reported around the world each year, which is about almost like 1,000 cases of paralytic polio every day was being reported. Where we are is that in 2013, these are the 3 countries now that remain that have never interrupted transmission of their indigenous virus, the virus that belongs to that geography for thousands of years. So we call them the endemic countries where endemic polio still remains: Pakistan, Afghanistan, and Nigeria. So this is the story, and this is the success that I think Claire and others have referred to, the spectacular success of the program, where you see a lot of polio and then rapid progress until about the beginning of this century, indicating that in where normative public health programs can be implemented, the progress was rapid, the strategies were effective, but clearly the program, by the year, there are 3 types of polioviruses: type 1, type 2, and type 3. Type 2 was eradicated in 1999 globally. We haven't seen that virus, wild-type virus, since 1999. But then the program kind of got stuck at very low level. I think Claire also referred to that, which means that there was a fundamental shift in where was it that the program was bogged down. And what were the adjustments. So over the last 10 years or more, the program has had to adjust and innovate both technically and operationally to deal with unique challenges as it has had to encounter very, very complex biological and political and social landscapes. And so this has been the challenge. So the next big victory came when Niger and Egypt stopped transmission of polio virus around 2005-2006 timeframe. And then, of course, the major success was interruption of transmission in India, with the last case being in January of 2011. And this is a major milestone in the program, because many experts even had questions whether it was biologically or technically feasible to eradicate polio in conditions like India. The social and cultural diversity, the challenge of environmental surveillance, the rapid birth rate. Many experts believed that it was not technically possible to eradicate polio in India, and that was demonstrated. The other reason why the eradication in India became so important was that once the technical issues were put to rest, the remaining issues were political and social. Is the political will there to complete eradication? Do we have the social linkages that will allow us to complete the eradication of the program? There was also a sense of panic and urgency in the world, because around the same time when India stopped transmission, there were 2 or 3 series of outbreaks that gave us a vision for what the future would look like if this program fails. And Claire already referred to one of those situations, was what we faced in the Congo. These outbreaks of polio were starting to affect not only children but older populations as well, where the case fatality is very high. We heard that in Congo alone, more than 180 people died of this very horrific outbreak. We saw that in Tajikistan as well, an outbreak that affect older persons, because the eradication program has changed the epidemiology of disease. In many countries, it's no longer a disease of childhood. If the virus gets there, it will paralyze older individuals as well. So because of a combination of these factors, it was in 2012 that the World Health Assembly declared the completion of eradication a global public health emergency, recognizing that if this program fails, not only we will get back to this situation very quickly, in a matter of 10 years or so, we will be back to hundreds of thousands of cases, but the fatalities that would be associated with that resurgence and with that failure would be a public health catastrophe. So having come this close, there is really no turning back, from a public health perspective. Now the final highlight of the progress is that we may have interrupted type 3 transmission also. We just heard from Dr. Jooma that the last type 3 virus was seen in one of these tribal areas in Pakistan in April of 2012. So it's been 18 months in Asia that we have not seen type 3 wild polio virus. And we have not seen this virus anywhere in the world. It was last seen in northeastern Nigeria in November of last year. So the progress globally is continuing. So if you look at the endemic countries only in the last 6 months, this is the disease we are seeing. Most parts of endemic countries, Nigeria and Pakistan and Afghanistan, are in fact free of polio virus. So as I said, we have not seen any type 3 since November of last year. There has been a 40% further decline in endemic polio virus compared to 2012, which was a year when fewest number of wild polio virus cases were reported. And we have not seen any endemic transmission in Afghanistan since November of last year. This is a very important development. These 7 or 8 cases we have seen in Afghanistan are a result of cross-border transmission from Pakistan. The endemic virus of Afghanistan that was in the southern region, which is this Kandahar area, that we have not seen since November of last year. So this progress in endemic countries is continuing. So this is what basically shows you the year-to-date comparison of cases. Nigeria has halved the cases. We are seeing some stagnation of progress in Pakistan, and I'll come to that. And then Afghanistan is looking extremely good. And these 7 cases, as I said, are actually related to cross-border transmission of Pakistan virus into Afghanistan. So this is all the polio now that we are seeing. And why is this happening? One is that, as I said, cross-border transmission from Pakistan into Afghanistan. The other is we are seeing silent transmission of polio virus. We detected it in environmental surveillance in sewage in Egypt, and then subsequently in Israel and West Bank and Gaza. And although there is no paralytic polio, but wild polio virus is still circulating in Israel. And there's a technical reason for that we can discuss if we have time. But the Horn of Africa outbreak following an importation from Nigeria. So we are learning this lesson over and over again, that as long as we have endemic transmission in countries and as long as we have vulnerable populations, the virus will spread to these places until we stop the endemic transmission. That is why it is so important to stop transmission in Nigeria. That is why it is so important to stop transmission in Pakistan. And I've already sort of given you this summary. Pakistan, we've heard from Dr. Jooma and also from Laurent. There are two sets of issues. One is the continuing threats and attacks on health workers, and particularly in Khyber Pakhtunkhwa in the Peshawar area, and those threats and intimidation have continued. And as a result of that, even though security is provided to some of the teams, there are still areas where teams cannot go, and the teams are still very tentative in some of the areas. So they are still missing hundreds of thousands of children that they cannot vaccinate. Okay, and the other area, of course, the other area is that of North and South Waziristan, where there is a political ban on vaccination. And you see that there is not only type 1 polio virus there, but there is also these green marks. They show you that there is a simultaneous outbreak of circulating vaccine-derived polio virus type 2, because we have not been able to vaccinate any children here since June of 2012. That's when the ban was imposed. Now, I am also from Pakistan, and I think it's very important that as we look and discuss the situation in Pakistan, that we separate the politicization of the program from what is the social acceptance of the program in these areas. How many families are actually refusing, how many mothers are actually refusing vaccination, compared with who are the people who have become the gatekeepers and are politicizing the program and are responsible for the violence. I think it's a very important differentiation that we have to make, and the position of the state in this situation, and we should have that discussion. Nigeria, again, two sets of issues. Nigeria has made tremendous progress this year. Northwestern states of Nigeria have no transmission this year, but we know that there was a state of emergency declared in northeastern Nigeria, particularly in Borno state, where since that emergency was declared around March, April, we have not been able to vaccinate anywhere between 500,000 to 1 million children in this conflict zone. And then in areas of Kano, the main problem remains of still some quality gaps, and we're missing children because of basic operational quality issues. And that this shows you that even though there was a lot of improvement happening in Kano itself, these are LQS, these are surveys conducted to assess vaccination coverage. Red is bad when you can't even achieve 60% coverage. Yellow is 60 to 80% coverage. Green is more than 80%. And then blue is more than 90% coverage. Even Kano was on an improving trend in second half of 2012. This is when these attacks happened in which vaccinators died, and they are still having trouble regrouping and getting themselves organized to vaccinate again in Kano, although the recent September campaign, they have shown much more improvement. This slide does not include those data, but just to show you that even in Kano, it is possible to actually improve the coverage of vaccination. Just coming to the outbreak areas that are affected by outbreak. This is the Horn of Africa outbreak I talked about. I mentioned the silent transmission in Israel, Gaza Strip, and West Bank. And most recently, some of you may have seen the news that there is a highly suspect polio outbreak in northern Syria. And we can briefly talk about that. This is the situation in Somalia. We are still dealing with the bulk of the outbreak is in the Benadir region, which is the Mogadishu and surrounding areas, but the outbreak has affected also some of the inaccessible areas in Somalia, which are not under government control, and where there is sort of a ban on mass vaccination campaigns in south central zone of Somalia. But the response to this outbreak has been outstanding. It's been very aggressive. A lot of new lessons have been applied in this outbreak: short interval dosing, bivalent vaccine use, and vaccination of the entire population. Some rounds in which the age group was expanded to beyond the traditional 5 years. And that we have learned that in an outbreak setting very quickly controls an outbreak. And you can already see that even in inaccessible areas and certainly in accessible areas, this outbreak has already peaked and transmission is considerably slowing down in Somalia. Now, so we are very optimistic about the interruption of this transmission in the Horn of Africa. And this is just some of our experience with the impact of vaccinating wider age groups in an outbreak setting. And this includes the experience we had in the Congo outbreak, where older persons were also vaccinated. Basically, you can shut down outbreaks much faster when you vaccinate children, persons older than 5 years, because older age groups can contribute to transmission as well. And so when you boost the immunity among older individuals, that we are learning can actually hasten the stopping of an outbreak. So this is the outbreaks, how long it takes. These are the median number of weeks to stop an outbreak. And you see that when you only vaccinate persons under 5, it takes you many more weeks to stop an outbreak compared to when you are vaccinating older persons. That sort of summarizes our experience. This is a map of the environmental surveillance sites. This is where sewage sampling is done in Israel, basically showing that there is wild virus circulation in Israel. So far, no paralytic polio has been detected in Israel, and we can talk about this. And this is the cluster of cases in the Darat Zor governorate of, this is Syria. This is the Darat Zor governorate of Syria that borders Iraq. And within that, there is this cluster of acute flaccid paralysis cases that looks very, very suspicious of a polio outbreak, so that Syria and the surrounding countries are already planning and taking steps to deal with this as a polio outbreak. We expect virologic confirmation by the end of this week, whether it truly is a wild polio virus outbreak. But Syria clearly has been at a high risk because of the deterioration of health services over the last 24 months in Syria. So in summary, we have not seen any wild poliovirus type 3 globally for more than 10 months now. No endemic virus transmission in Afghanistan. Large parts of these endemic countries, Pakistan and Nigeria, are free of active transmission. It really is restricted to very specific zones. And that the impact of the outbreak response in the Horn of Africa has been quite evident now. It was a robust response, but we have clearly major challenges. We have about 2 million children who are living in areas which are inaccessible to vaccination teams, because these are either conflict zones or there are directed attacks and insecurity, overall insecurity on the program, as the polio program has become a kind of a political bargaining tool for some of the specific elements, particularly in the context of Pakistan. There are still some areas where there are quality issues in operational quality issues that need to be improved, particularly in Kano and parts of Nigeria. And then we've had some delays in response to wild poliovirus transmission, particularly in places like Israel, who were very slow to respond to the detection of virus because they no longer use the oral vaccine. And it was a big deal for them to reintroduce the oral vaccine to control this transmission. So how is the program dealing with this? And I'm not going to spend too much time, but these next couple of slides represent to you the major shift in our thinking and in the program, from largely a technical and strategic to one which really begins to engage with the social and community and the political aspects of the program. So one of the major priorities right now is that how do we position each of these infected areas for the low poliovirus transmission season that is coming up in early 2014, because that's when the poliovirus transmission slows down. That's when the chances of success are highest to stop transmission from a epidemiologic point of view. So there, of course, there is a lot of work going on in developing very area-specific plans. You can't have one-size-fits-all strategy. Even within Nigeria, different strategies have to be applied in different areas. Similarly, in different areas of Pakistan and Afghanistan, you need different locally tailored strategies, local initiatives to engage the communities through trusted intermediaries. Reprofiling of the program by engagement of third party voices becomes very important, and that leads to development of new partnerships at the global level, at the national level, and at the local level in particular. And of course, developing a security and a different operational framework that is much more flexible, that takes into account all of these elements, so that if you look at how these risks are being managed, one is negotiating access. There is a element of the government and neutral third parties that are involved in negotiating access, and we've had a lot of success with that in southern Afghanistan. Our teams have been negotiating. That the Taliban in Afghanistan are very supportive of polio eradication. They write letters of support, and they have engaged with the program in specific areas to allow access, which has enabled us to stop transmission in the endemic areas of Afghanistan. A international Islamic advisory group has been convened under the leadership of Al-Azhar University in Cairo and the Islamic Fiqh Academy in Jeddah, with the membership from major Islamic institutions that represent all sects of Islam, and their complementary bodies are now being established in Pakistan and at the country level. So already there is a national Islamic advisory group based out of the Islamic University in Islamabad, and key nodes have been identified in FATA, in Peshawar area, in parts of Karachi, these key religious institutions that are important to engage the religious leadership in these areas. And then, of course, engaging all community leaders through tailored communication, using broader health platforms, the kind of Polio Plus. What else can be provided to these communities, which are very marginalized, that don't have health services, that, the points that Laurent, made very strongly, in his intervention. And then, tactical adaptation. How do you maintain operational flexibility in the program? Short interval dosing, short duration, vaccination of older age groups, optimizing the vaccine mix, and then other vaccination strategies to vaccinate populations in transit, the mobile populations, and then bringing a total management focus to the program. And these are some of the quality issues that are going to be important, but I'm not going to get into those details right now. So I hope this gives you a flavor of the progress that the program is making, but also the major shift over the last 2 to 3 years in the program to actually adapt to the challenges it is facing in very specific areas that are mainly social and political challenges, so that this is a program that does not only need technical expertise, it certainly needs the social and political expertise to be able to engage these communities and operate effectively in these areas. And of course, we have a number of comments on the earlier comments that have been made, but hopefully they will come out as people ask questions. So thank you very much, Claire.
I'm very pleased to be here and giving a somewhat alternative view on the Global Polio Eradication Initiative. I've been doing work in Nigeria since 1990. Well, actually 1987, but I moved to the northern part of Nigeria in 1994 as a Fulbright scholar, and I was working in a community known as Zaria City. And just to give you, this is a theater for development performance in Zaria, where they were, showing about what happens if you don't get your kids vaccinated. Oops, the left. Okay, so we've seen. Dr. Jafari explained about the outbreaks. This is the area where there are the most number of polio cases right now. Zaria, Kaduna State, I believe, is polio-free this year.
At least this year.
This year, yeah. Last year they had. And Zaria is in Kaduna State. So let's see, can you see? Here's Zaria right here. And here's Kano. So they're fairly close, and there's a fair amount of travel back and forth. But this is the area where the most cases are this year. You know what? Yeah, exactly. So just to give you a sense of what my research has been in Zaria City. I'm an anthropologist, so I know that most of you are not used to social sorts of evidence. Okay, I just wanted to say something about this. This was actually one thing that got me interested in the polio campaign, because one of the major complaints about polio vaccine in Nigeria has been that it contained family planning or some sort of substance that could cause HIV. And so I had run across this problem myself when I was doing research. When I first moved there in '94, I just did a really small survey of women's childbirth practices. I was really curious about the fact that most of the women in this community preferred to give birth at home. And so I was asking about childbirth practices and things. And as a gift, because it's so hard to get change in Nigeria, I gave out bouillon cubes, little Maggi bouillon cubes, because they were easy to buy a packet and give people. Everyone uses Maggi bouillon cubes. The rumors started circulating that I had put family planning in those Maggi cubes. And so that sort of got me thinking, or made me realize that when people are suspicious of something, they don't know why people are focusing on something or giving out something for free. And this is what happened with polio, actually. It was given out free. There weren't other things that were given. It was unlike the smallpox program where they were also giving measles vaccination. There was a lot of resistance because people didn't understand and they were suspicious. It was coming from the West. It was given free. And there's a history, actually, to this sort of suspicion. So that was sort of one of the things that got me interested in the polio eradication initiative initially. I mean, I'm a medical anthropologist, but I work on reproductive health. I don't really work on polio, or hadn't in the past. So the other thing that, well, this was another aspect of it, and although it was, at the time I didn't realize it, the cerebral spinal meningitis outbreak in 1996 in Kano that was associated with Pfizer. Yeah, the Pfizer was had a drug trial, and everybody. This is so funny because a lot of people don't, at least in the States anyway, and Pfizer is a U.S. corporation. They don't know about it, but everybody in Kano knows about Pfizer. They say, Pfizer. There was a drug trial. I think about 7 or 8 children died. And what happened was the Pfizer people came in and got somebody from the Ministry of Health to cooperate with them in Kano, and shunted, parents with their children into a separate line where they were getting Trovan, they were experimenting with this drug to see if it was viable for children as an antibiotic. And I won't go into that. There's a whole story about Trovan you may or may not know about. But this led to a real backlash with polio, because then when people were suspicious about where this drug was coming from, what polio vaccine was coming from, they were thinking of Trovan. And this was also, a free intervention by a Western organization. So I initially started working on the polio eradication initiative in 2003. I was doing basically newspaper collections from newspapers in Nigeria, talking about the ban, and this was mentioned by Claire, of in Kano State, the governor put a ban on polio vaccination, and this lasted for almost a year. And there was a huge surge, as you remember, after that, although it wasn't. There were other reasons for that surge as well. But anyway, so I just want to, go on to the next. Then skip that. So here's the information. This is the latest information. Okay, you saw a nice map showing this, and this shows the same figures that, and you can see that the endemic countries are really reduced from last year. And here's Nigeria. So they've done quite a good job in reducing the numbers. And like I said, that the areas where polio is still being transmitted are in areas where there's this political insecurity. And Dr. Jafari also mentioned that the polio health workers being killed, I believe, in February in Kano. And so when I went back, I was in Zaria in March this year, and I just asked, it's really tricky talking about polio. So there's certain people I can talk to about it. And I went to see this one woman who I had known for a long time. And I was asking her, I was curious about whether people actually knew about the killings of the polio workers in Kano. Zaria, is somewhat south. She said, I heard that in Kano there were some polio workers that were killed, about 7 of them. And I think that is why women don't want to go in for polio in Zaria City. She's meeting the health workers. And what's happened is that the health workers are now going around with a police escort. Okay, so this one thing that's going on in Nigeria. And in our area, the police, they went house to house, they arrested husbands. There was some bombs that were set off in Zaria City. This was the end of 2012. So what I'm suggesting is that there is this parallel of violence that's going on in Nigeria. One is police violence against civilians, as well as police, trying to tamp down this Boko Haram movement or related disaffection with the government there, and trying to get rid of polio. So what happened was they were breaking into houses. The police were breaking into houses at night and taking away people's, sons and husbands. At the same time, the police were going around with polio vaccinating teams in Zaria City. So it's that parallel dilemma that really, I think, is at the heart of some of this resistance, which continues. And just to say something, I don't think that the problem in Kano is just operational. I think it has, it's true, you said it, politics as well. But there's a lot of resistance in Kano still to the polio vaccination initiative, and it has to do with this idea that it's a Western intervention that's not helping people in their everyday lives with electricity and water, which is really one of their main complaints. This was a photograph that I took in 2012. I think it was in July last year. And this is just to show you, I love this picture because, she has such a suspicious look. And I actually know these people. But I was taking a picture of this. This is a slew of houses along in Zaria City where you can read this. There are 4 kids in the house. None of them were vaccinated. And the part about this is sort of interesting to me is that the man who's the father, the head of this household, he actually is, he has a university education. He's opposed to it, I think, on the grounds of vaccines are unsafe. So he's not picking up on the same sort of anti-political, anti-Western thing, although that might be there too. But he's picking up on this idea, and this is being circulated by a professor of pharmacology at the main university in Zaria, that vaccines are unsafe, just like people in the United States who are opposed to vaccines. So that's another strain of this issue. And then Claire mentioned briefly that there was coercive measures that are being taken. This is what, to me, is a problem with eradication initiatives. We've had 2, so it's not that you can generalize that much. But when you're getting down to these small kind people really want to push to get those numbers to end transmission. And sometimes they'll take actions that are kind of drastic. This one actually, I think this is sort of unethical, but it's not exactly arresting people, which is actually going on in some parts of Nigeria. If parents don't get their kids vaccinated, they risk being arrested. In this case, basically, this is one of the strategies, and there's a term for it, which I can't remember right now, but basically they'll find children wherever they can find them. If it's on public transportation, if they can get them attracted by giving out candy, they'll do that and give them OPV without their parents' permission. And I guess my question about this is, this isn't something you could do here. It's not something you could do in the United States, but it's okay to do it in Nigeria. And I just question, is this a valid approach to public health? Okay, and this comes to this famous paper by Paul Greenhall about the use of coercion and intimidation in the final phases of eradication. And there's a very famous paper that was published in Social Science and Medicine about what happened in India. And I don't think anything quite like the things he describes are happening in Nigeria. But the problem in Nigeria is this conflation of police brutality, politics, and trying to eradicate polio or break the transmission of polio. So I think I just want to be a little bit more positive. I think we need to think, and this has actually been raised, we need to think about who has the knowledge that counts in these situations, and getting Muslim political leaders involved in the North is really important. Getting parents involved somehow, and something about thinking about these rumors that are still continuing. Every once in a while they come back up, that there's family planning in these polio vaccines. Where are these coming from? We need to know a little bit more about that. And engage local authorities in the implementation of vaccination programs. And this is where I'm getting to what I really think we need to really beef up is routine vaccination. Primary health care, through primary health care systems. And this has been the problem all along in Nigeria, especially in the north. Primary health care is really just in shambles. It's been that way since the 90s. One program that I think is really interesting, I don't know if you know about this, and I don't know if it's continuing, but they were doing this was just outside of Abuja, which is the capital of Nigeria. They were doing a cash transfer program to encourage, and this was started by the Minister of State for Health, Mohammed Patti, before he resigned. They were doing a cash transfer. A mother was given a certain amount of money. It wasn't a whole lot, but she was giving a certain amount of money to come to clinic for antenatal. Then she was given a certain amount of money to come to deliver at the hospital or clinic. Then she was given a certain amount of money to come back for postnatal care and to bring the infant for immunization. And this is how you get them into this practice of going for routine immunization. And that, to me, is really where we need to be going. And that would take care of polio too. Maybe not within the time frame we're hoping for, but somewhere along that line. All right, well, that's really what I wanted to say.
Merci beaucoup, Elisha, pour cette présentation. Beaucoup de choses ont été dites.
Thank you so much, Elisha, for this presentation. After Dr. Jafari's presentation, it's really enriching. What I would point out from what you said is the dilemma, and that's what Dr. Jafari was saying as well, the need to separate political and social issues, whereas all those are parts of human life. It's intertwined, particularly when you talk of public health. It's really intertwined. And where it gets more complicated is that the GPI expects a strong political will on the part of politicians to help them convince the population abide by this imposed public health measure. Elisha mentioned that in Nigeria, apart from the field anecdotes from the field, I guess that the state of Niger recently put some hundreds reluctant parents in jail because they wouldn't have their children vaccinated. Some paid a fine and were bailed out, but others stayed in jail for a long time for the deterrence effect they were hoping. Following the murder of polio vaccinators a few months ago, it was the Kano state authorities, I believe, they arrested journalists who had just taken part in a local radio program criticizing the local immunization campaign. They were arrested for inciting people to hatred and for breaking the law and order. So discourses and practices are getting more radical, driven by the strong will of the campaign leaders to strike alliances with the local authorities in combating polio, but they in turn lead to a radicalization of the social and political resistance that they stumble into. And this should question us, like what you said, Dr. Jafari. You said it's a no turning point adventure, no way to go back on the way to eradication. We might come back to that in our discussion.
Mais pour enchaîner avec Florence, je pense que la transition.
But now I turn to Florence with an easy link with what Elisha was saying at the end of her presentation. Whatever happens, in order to reach the objective of polio eradication and try to protect the polio vaccinators who are exposed because of the high profile of this initiative, maybe we need to think about beefing up routine immunization. You've had many years of experience in vaccination. What can you tell us? Well, don't remind me the many years I spent working on polio. Well, what we see is that during the 80s, many efforts, lots of efforts were deployed to roll out vaccination programs, a great deal of commitment. That commitment lessened over time, and we saw the arrival of vertical programs, eradication of measles, tetanus, polio, and such programs became predominant, as it were. I'm not challenging the aim of those programs, which was to speed up the impact and benefits of immunization, but we can only see that some imbalance came about with time. And in a good number of countries, extended programs for immunization came to a stall. They don't work anymore. That is, people don't have access to regular routine vaccination. They're not helped or encouraged to go for vaccination. It's all going to the dogs, I would say. And in those areas, of course, it's true, general access to healthcare is not good at all. So there is kind of an imbalance, even though it's not what the program, the initiative was targeting, of course. But the more we'll vaccinate, the fewer diseases we'll have. The fewer diseases, the more resistance we'll encounter. There will always be resistance to vaccination. Should we force everyone to get vaccinated? I don't think so. Everyone, have their own idea on the issue, but I don't think we should impose on everyone or force people to get vaccinated. But we should shift our approaches. We should offer vaccination through those vertical programs, but it should be coupled with healthcare provision, healthcare offer. It's what we try to do in our programs. It's not always easy. It doesn't rest just on the will of vaccinators. It rests on the will and responsibility of the healthcare personnel to ask the right questions, to be attentive, to make the link with the nurses and people who see the patient and refer the patient. But today it's not the reality. In the best cases, we do vaccinate regularly. I'm talking about the missions, the projects in which we work. But this is not generally true in all the countries, far from it. Anyway, I do believe we should review our approach with those big vertical programs. Another thing we mentioned that is the over excess predominance of polio. Every year we're faced with the outbreaks of meningitis, less than before, outbreaks of measles as well. And when facing such epidemics, when we try to respond to such outbreaks at the same time as a polio campaign is being conducted, we cannot find the right time slot. We discuss, we bargain with the authorities, but everything becomes more complicated for us. And so diseases which are a greater burden on the population, such as measles or meningitis a few years back, because of the polio focus, we're delayed in our routine efforts to combat meningitis and measles. We're hampered, and I think we should couple all those programs together in a more synchronized way.
And I think it's a combination of both the opportunity. First, as you well know, that not all diseases are eradicable. You know, there are certain criteria a disease has to meet to be eradicable. And, you know, and the fundamentals are that, you know, humans are the only reservoirs and that you actually have a tool that can prevent transmission, and it doesn't have an environmental reservoir. And then, of course, other enabling factors like the political will and the financial support and all of those sort of comes into this. And it's a tough question to ask, because I think people always look at the opportunity. In retrospect, can you imagine if we had not eradicated smallpox and then had the HIV epidemic around the world? We could not have vaccinated with the vaccine we had, because the vaccine would be killing HIV-infected persons. And you can imagine the horrific effects of HIV and co-infection with smallpox virus. We didn't have to face that disaster, because opportunity was taken to eradicate smallpox with a vaccine which today would not be licensed in any country. But it prevented a major public health disaster. Today it's polio. People are talking about should next be measles, because measles meets the definition of being an eradicable disease. And you know, the question is not settled yet, because there are those who say it's an opportunity. You have the vaccine, you have the access. Now you have learned from polio eradication program. And a lot of the measles campaigns actually have been implemented by the polio eradication workforce in many of these countries in Africa. Personally, myself in India, you know, in the final stages of polio eradication, the same infrastructure of polio health workers, WHO, UNICEF, and government workers, they vaccinated more than 150 million children against measles in the areas of Bihar and UP that had the highest measles mortality. So the question is, you know, it's a question of opportunity, and it's still not settled, because people are feeling the other way, that, you know, the political and social challenges are such. Can we politically and socially eradicate measles? And so the debate actually in the international public health is continuing. So I cannot give you a yes or no answer, but we in public health should always look out for the opportunity, because we don't know what happens in the future, and smallpox in the context of the HIV epidemic is a very important lesson that we have learned. Back to you.
Recently there have been a couple cases, probably more, but I'm either hear them from people or read about them in the newspaper, where people are using polio. If polio vaccinators want to come into a village, and I'm thinking of Kano State actually, in rural areas, where there's no light, there's no public health clinic, there's no water, and they'll say, all right, you can come in our community, but you have to build a borehole first. So in a way, what people are doing, they're challenging. I mean, the other part of it was, why are you just doing polio? Our kids are dying from measles and malaria. And initially, they weren't doing, when they introduced Polio Plus days, and that was in 2006, I believe, things got a lot better. So it was a way of local people saying, you're not doing what we need for our public health, so we're not going to cooperate with you. I think that's what you're asking about, correct? Yeah, so I mean, I think that the government, Dr. Pate was really terrific at sort of trying to figure out how he could work with communities. And I think I think the cash transfer scheme was one possibility. Another thing is finding out what communities need and working with them in terms of basic amenities. Just an aside, but yesterday in the big northern Nigerian newspaper, there was a report that the main transformer for all the electricity in Kaduna, which is a major big city in the north, completely went down. And I mean, it's that sort of infrastructure that needs to be built up.
No, I think, as I sort of referred to in my presentation also, I think we need to unpack the violence we are talking about a little bit more and the coercion that we are talking about. We should unpack that. I think we are kind of using very broad statements to paint everything with kind of one brush. And I say that because there is with that unpacking, I think we can get some insights as to how do we manage. Because it's not a question of whether if we stop eradication, all of this will go away. Because what's the next program in line? There is attack on education. There is soon going to be attack on primary health care as well. Because if we are only using violence as a measure whether we should do public health or not, where do you draw the line? So I think we need to unpack these issues very, very carefully. And so first, in terms of, there is, in anything, there is a right way to do things, and there is a way that you can muck up things. You can really, and we've learned this lesson, in our community engagement in many, many places. And my most direct experience has been in India. A much larger population had a much more organized resistance to vaccination in the Muslim minority populations of Western Uttar Pradesh. And there they used to, in fact, the community used to attack vaccinators, because this all came to a head when the political alignment was such that there was a BJP government at the center. There had been a history of forced family planning in a previous government in India, and this was being done house to house in a setting where there were no health services. And so the program had to take a number of steps over a long period of time in engaging the political leadership, the academic leadership, the religious leadership, and community leadership, systematic neighborhood by neighborhood, to build a bridge, a trust with these communities. So when around 2002, 2004, you saw a clear disparity in vaccination rates between Muslim and Hindu children in these areas, and high levels of resistance in Western Uttar Pradesh, that was systematically addressed. Taking people from those communities and getting them to vaccinate their own children. Taking other measures, getting the right kind of medical officers working in those areas, engaging the communities in taking control of the vaccination program in their own areas. And these things work. And ultimately they worked, and you could see over the years resistance melting in northern India, which was one of the major challenges to stopping transmission in northern India. We've learned this lesson in many other places, and this is also being implemented in parts of Nigeria now, because unless you build that trust and you engage these communities. So the point I'm trying to make is coercion is not the strategy of the program. Coercion is either a poor implementation of a program locally, or when it is mixed in with some other, as you said, co-inflation of when there are some elements that are creating difficulties which are not targeted to a particular program, but it's a political activity that's kind of mixed in with a public health program, and the government starts to take some action on it, then it starts to look like it's coercion. So we need to look at that very carefully. And I'm not saying coercion is not done in some places by the local workers, it's wrong, it's against the strategy of the program. Because the strategy of the program is to systematically engage the communities. And in many places, there are successful models, even within Nigeria, of that, of engaging the communities. That's why we've seen the kind of progress we are seeing. Even in Kaduna, even in Zaria, people have been able to engage, train the vaccinators to be able to answer questions of mothers when they ask those questions, so that there is no forced vaccination. So I want to unpack this further. Now let's talk about the violence in Pakistan. This violence in Pakistan, if you look at the overall data, the target population of children that are vaccinated in a national round in Pakistan is 33 million children. The families that refuse vaccination are less than 0.5% that actually refuse, even today, given the political situation in Pakistan. And when you unpack even that refusal, a lot of it is related to lack of information about the safety of vaccine. Okay. And there is very little that relates to what you read in the newspapers, that it's because of the way they captured Osama bin Laden or the drone attacks and all of that. A mother at the doorstep doesn't say that I'm not going to give, even in Waziristan, a mother does not say that I'm not going to accept vaccine for my child because you used a vaccination campaign to capture Osama bin Laden, or that the drone attacks have to stop. We have to clearly separate those who are using this as a political tool. And today it's the polio program. Tomorrow, if you stop the polio program, it will be another program that would be held hostage to this politics. I'm sure you have read newspaper stories where families are coming out of North Waziristan to take vaccine and take them back into Waziristan to vaccinate their own children in a way that those Taliban don't find out that they have taken vaccine back into these areas. So to say that this violence is being perpetrated by the program, I think what the government is trying to do is to allow these vaccinators that come from those communities to be able to vaccinate their own communities. That's the state's responsibility. When you look at a government perspective, if the basic services start getting attacked, as I say, today it's polio vaccination, tomorrow it's primary health care, it's education of women. If they start getting attacked, does the state accept that as that is fine, or accept that as the will of the people? I don't think so. I mean, I think the government of Pakistan is responding like any government would, that if we have a program to deliver to our communities, and the communities want that program, we have to provide the security and protection to those workers who come from those communities. They are not being imported from America or from Europe to come and vaccinate. These are people from those communities who are getting out and vaccinating children in their area. So I feel that we need to unpack all of this and then address where there are problems. I'm not saying that the program does not have problems. There are incidents where there is coercion which should not happen, and we need to fix those. But that's not the philosophy or the strategy of the program.
Juste pour clarifier mon point de vue,
I just want to make myself clear here. I'm not saying that coercive measures should not be part of the programs. When we set up massive vaccination campaigns, we do use coercion because, when you look at hundreds of thousands of people that we have to immunize, sometimes we cannot afford to be in an individual negotiation of the cost and benefits of the vaccine with the person that we have to immunize. The question is not about morally judging coercion. The question is, when you see this reality, the human reality in the field, which is that 100% of a population cannot at all times and in all places, for political reasons or religious reasons, or reasons which have to do with everybody's individual freedom. So given this reality, should we fight against the reality in order to reach our objective, or should we just make do with this reality and review our objectives and have maybe more reasonable objectives in terms of public health than 100%, And a more reasonable objective than total eradication. And back to the lessons learned, there's one objective that we have not mentioned, which I think we have to mention as MSF, which is that the polio eradication campaign demonstrated, at least during the first 12 years, when it enabled this dramatic drop of the number of cases, it demonstrated that when science and donors and politicians work together towards the same objective, we can reach very interesting results. So my question, and I realize I'm being a bit provocative here, is could we maybe try to keep the same level of mobilization as the one we can achieve with the Eradication Horizon? I'm talking about donors in particular, while giving up eradication as an objective, so that we can actually maybe achieve this in some areas in the world. I'm thinking about 10 countries in the world where child mortality is unacceptable, so we should try to reduce it. So could we maybe have the same means as we had for polio for other public health issues, which seem to be more realistic or maybe even more reasonable?
Ça marche comme ça? Ah ouais. Je peux revenir un peu en arrière.
If I may go back in time, in the 80s and 90s, in this very building, we had discussions on vertical versus horizontal programs, and the accused was the EPI, and the program we used to blame or cast the blame on was the vertical programs. I think we have to carry our flag high. EPI did it for health policy, and I think that's what we're trying to achieve now. Then I hear the reason for our eradication efforts to fail is the reluctance or refusal by the populations. I reckon refusal is a problem, but it's seldom mapped or quantified. I remember big discussions in Katanga. We were saying there are some 150 sects that refuse, but some sects comprise only a couple of individuals. So when you look at the reality, it's very small, those who refuse. If 3% refuse, but if we vaccinate the remaining 97%, we'll eradicate polio in the world. So the main cause, we're talking about refusal, rejection in Nigeria. When I go to Nigeria, what I see is that our operational standards are working, but one team cannot vaccinate more than 250 children a day in urban areas. Otherwise, they don't have any family life, any time for themselves. A team used to vaccinate 700, 800, 900 children a day. Can you imagine? So we talk lots about the refusals, but no one says that from the operational standpoint, it's impossible. The strategy is bound to fail. Well, it just changed 2 years ago. An Indian group went as a consultant in Nigeria, and they managed to change the situation in the north, but not in the south. And even where they succeeded, I visited Zamfara, Kosoto, 5, 6 states. There have been huge progress, hence the drop in the number of polio cases. Now, in the north, they have 1 supervisor per team going with the team, but the supervisor doesn't behave as a supervisor. He just walks about with the team, so there is no impact. There are some operational constraints which are usually used as a main reason. It's true, some people refuse vaccination, a few. Like we used to say, oh, all the polio cases come from Angola. Now we see indigenous transmission in Congo. And in all the meetings, people used to blame Angola saying the virus came from Angola. And I used to tell them, yes, before Angola it was an Indian virus, but now it's your virus. You have to take care of it. Of course, we can live with a couple of cases, but I did a quick poll in the corridor here, and 20% of the people I talked to have not been vaccinated against polio. Yeah, refusals are a serious problem, but we should quantify them precisely, and we shouldn't use refusals to hide and mask very serious operational problems in actuality. Now, my colleague answered same thing as I would have on the previous question. So yes, we can challenge a bit the way we go about it, but I do believe as well there is no way back, no going back, and we have to finish with it that quickly.
Thanks. I think the security framework has many elements in it, and it first starts with the aspect of empowering the communities, because the most important thing is to make sure that the communities in which you're operating, whether they support the program or not. And so first of all, making sure that the communities are fully engaged, they trust the program, their leaders are involved, and the vaccinators and supervisors are coming from the community who the community knows, because that's the most important element of ensuring the security of workers, is because the community itself then becomes a common defense for attackers from outside. Just know that these people who are killing vaccinators are not from those communities. It's very important to recognize that. Second element of that is that the local authorities know the local situation and security situation very well, and they have to continuously undertake security assessment. What is the evolving situation? What is the security situation? And apply and security plans and deploy security assets in a way that is not threatening to the communities. And there is a way to do that, how they cordon off, even in parts of Pakistan. Somewhere it's done well, and some parts they're still trying to do this well and are not succeeding. And in parts where they have done well, they have applied security assets strategically so that they provide protection without the community seeing a lot of armed groups walking around street to street or house to house. So the point I'm trying to make is the local authorities conducting security assessment, they know their areas well. So if you have a highly committed district commissioner, he or she applies very good security to their area where vaccinations can be conducted. The third element, of course, is the operational flexibility that goes hand in hand with the local security situation. And that is in certain areas where normally you would vaccinate the neighborhood over a 3-day or 4-day period, you reduce the exposure of the teams and you bring in extra teams and complete that activity in 1 day instead of doing it over a 3 or 4 days. So you reduce the exposure time of the campaign. The fourth element is engaging the communities, but not widely publicly announcing, on television and on radio, that what are the dates of the campaign for a particular area, so that it's all managed locally. The fifth element is ongoing work between rounds of engaging the communities and establishing broader health services in those areas. So for example, one of the areas where the first killing started in Karachi is an area called Gadap. You may have read about that in the newspaper. This is a community that was not planned in Karachi. Basically, it developed around migrants who came from Khyber Pakhtunkhwa and the tribal areas, and it was an unplanned community, so there was no health center there. Okay, so the program has worked with the government and local authorities to establish a local health unit that provides primary health care and that provides vaccination. Okay, so that's starting. Rotarians in Pakistan, in Karachi, they have established a health resource center that provides broader health services, maternal and child health care in this area. These are very important steps to build trust and engagement with these communities. Now young women from those communities are coming and working in these health centers and are starting to work as vaccinators in these areas. So this is a multi-dimensional security framework that includes not only all what you see is a policeman walking with the vaccination teams, but that's not the only thing that is happening in these areas. A very sort of multifaceted strategy is being applied in these areas to vaccinate children. And it's not all completely done yet. I think some areas like particularly Peshawar, they still need a fair amount of work to do to get this right. Thank you.
Bonjour. Je suis quand même surprise par
Good morning. Well, I'm surprised by the measures taken by the Pakistani government, particularly regarding polio. We were making the link with family planning, the whole issue of family planning, which is also being scrutinized by the Taliban in Pakistan. Since 2007, I believe, there's been a ban on family planning in Pakistan, so that in the Khyber Pakhtunkhwa's provinces, for example, in many places, the women in charge of doing family planning stopped coming to work. They used to come to hospitals where they would distribute contraceptive means, and they stopped going to work because they're highly targeted. The lady health workers, as they're called, who also help with vaccination campaigns, in their remit, they were allowed to do family planning activities in their own community, and they stopped doing it. They've stopped doing it for nearly 5 years now because they were threatened. And there is no talk of coercive measures on the part of the government. So I was surprised by your answer, sir, when you said, well, then it's going to be the schools, but girls' schools are already being attacked, and then they will attack another health program, and yet the government is not placing military around the lady health worker who is still trying to do deliveries and family planning activities. They don't get any help or protection. So even though the communities are trying to get immunization, well, they might become suspicious when they see all those measures deployed for this particular activity and not for others. So in order to continue the fight against polio, because in Fata or Kepike, the communities are very scared at the prospect of having paralyzed children again in the family, and they realize they are at risk. So maybe having two different types of strategies, like continuing with polio days in Punjab or in the Sindh, where it's well accepted, and leaving it to WHO and KPK's programs to work differently. So a twofold strategy, or two different strategies, instead of continuing speeding up and sticking to the same model. Would WHO and donors...
I think it's a very important question you've raised. I think the first part of your question is that why there is a difference in government approach on polio eradication and family planning. And I would give you a two-part answer. I think the first part of it is clearly the government is under tremendous pressure domestically and internationally to stop poliovirus transmission. They know that they are a source of virus that is affecting other countries. It's affecting Afghanistan. Pakistan virus caused an outbreak in China in 2011. Pakistan virus is now in the Middle East. And so they are under tremendous pressure to not be an international risk for a global public health issue. But that's not to say, I completely agree with you that the government has to really take a very aggressive approach on anybody intervening or coercing towards delivery of basic services. I don't think that the government should tolerate that. That's my view as well. I think my second part of this answer is that, polio eradication, and we all need to step back a little bit, is to think about this, that it is a program that has an imperative that it has to reach everybody, no matter where they are, and what kind of views they hold. They have to be reached somehow. And the program has to find those solutions to reach them. But this mandate, this imperative, puts to test everybody. The international community, it puts to test the governments, and it puts to test the local authorities and even communities, that is everybody there playing their part so that children can be reached. And so perhaps this experience with polio eradication will be learned by the government to apply as there is going to be interference towards other social and public health programs. One hopes that the government, once it learns from this polio eradication experience, can begin to engage with the communities and with the lady health workers so that they can do their jobs more effectively in areas where they are truly threatened. I think that's an important perspective. You had a second part of your question, which I'm forgetting now. Can you remind me the second part of the question was?
To combine, to have a...
Yeah, the different strategies, yeah. So, no, I think that's key. Yeah, so what I think, what I've tried to explain is that even though the overall strategy is to vaccinate children, but already the way the program is operating, even in different parts of Pakistan, even in different parts of Khyber Pakhtunkhwa, because the problem is not all across Khyber Pakhtunkhwa, it's the greater Peshawar area, and then program is working in most of the FATA agencies. There is a problem in 3 agencies, in Khyber, North Waziristan, and South Waziristan. The way the program is operating, even within these districts, is different according to the local situation. So the strategies are being adapted according to the local situation and challenge. So it's not one strategy or 2 strategies. There are multiple strategies that are being adjusted and adapted according to the local social, political, and operational environment. We can't, as I said, there is no one size fits all. You have to tailor the program to the local situation. The polio eradication program has really been very effective in identifying and accessing all populations that were not on any public health map, whether it is in South Sudan, even in Nigeria, even as recently as 2011, the program has identified more than 40,000 nomadic and border settlements in Nigeria that were not on any map in Nigeria. And the kind of technology that has been brought of satellite mapping and GIS mapping to identify these populations is unprecedented. So, right, exactly. So this information is now available to all public health programs in Nigeria now, okay? As an example, in South Sudan, when the first campaigns of polio started in the 98, 99, there were many populations that were not on anybody's map that the program put on the map, created the bridge, and now you actually have a public health system functioning in South Sudan. Then once this happens, then the road is built for other public health delivery. Again, I come to the South Sudan example. On the polio surveillance, polio immunization has been built, the early warning disease outbreak system in South Sudan, and vaccination campaigns against measles and other outbreaks. In Somalia, now the routine immunization coverage is around 60%. There is no Ministry of Health that's delivering that vaccine. A lot of that happens through the immunization plus days with distribution of bed nets, distribution of vitamin A,
distribution of vaccines that is basically built on the micro plans for polio eradication and is done led by the WHO and UNICEF, hundreds of workers that are still in Somalia doing this work. That's the opportunity. The third area is of disease surveillance. Most of the integrated disease surveillance system in Africa is built on the polio surveillance system. The whole disease reporting system, the laboratory networks where these diseases get confirmed are built on top of the polio virus laboratory network. Now there is yellow fever laboratory network that's built on that, measles laboratory network that's built on that. So there is a lot of opportunity that has been taken on the polio eradication program. So there are aspects of this that are way beyond just eradication of polio. But the program has actually failed at communicating this appropriately and framing this, that how this has happened. But if you go back to the areas you work, I'm sure you can relate to what I'm saying, that many of the planning tools, many of the access that has been established has actually been done. The Hans Everts sitting here is a pioneer in taking the cold chain as far as you can when there are no refrigerators available in South Sudan and places like Somalia. That has been used now for other vaccines. So there is a lot of contribution. VVMs, vaccine vial monitors, is an innovation of the polio program as part of that cold chain element. So just a few examples of the opportunities.
Johannes and Elisha, you wanted to comment?
Oui, je crois que je peux pas.
Yes, I think I cannot stress enough how much, if some people are fed up with polio, it's us, you know. Nobody's more fed up with polio than we are. So if you have some ideas to totally eradicate it, well, then you're welcome. 800 million, 300 cases per year. You cannot stabilize polio at 300 cases per year. It's either you win or you lose. So stabilize it at a few hundreds, a few thousands per year. How about we do that? Well, then show me the algorithm that would enable us to do that. I don't know. I mean, I really don't know. It's success or failure. If it's failure, well, maybe it's not going to be 200,000 cases. Maybe routine immunization will improve, but it will be at a very high cost. And then in 10 years from now, everybody will think, oh, at the time they only had 300 cases. Why didn't they just finish up the job? Well, we will be there to testify of all the good reasons that prevented us from finishing the job.
Commend WHO on the initiative to attract these nomadic people to come bring their children to get vaccinated. They had the brilliant idea of getting salt licks. These are cattle raisers. And so they brought their children to get vaccinated because they figured out that salt licks for the cattle would be something that would bring people to bring their children. I want to come back to the politics issue a bit because I'm just worried that you mentioned that Pakistan is under pressure from the international community to cooperate with this polio vaccination eradication program. And I think that Nigeria is also under this pressure to cooperate with the polio initiative. But the problem is in Nigeria, when the government's under pressure like that, they tend to use coercive measures. I mean, coming back to that term. And in the Northeast, where this is the problem where the most cases are now, the government has set up a state of emergency where we have very little news about what's going on there. And I'm just concerned. I mean, there was a recent report, Amnesty International reported about the number of people who are associated, who've been said to be associated, who picked up by the government and put into basically prisons where they have no recourse to any kind of legal protection. I'm just afraid that the government isn't in a position to both eradicate polio in that area, to end transmission of polio in that area, unless they can think of a political situation or political solution that's not based on arresting, violence, basically. They need to negotiate with people and figure out a settlement. That's where I think things need to go.
May I just respond? No, I think that's absolutely clear that I think both in Nigeria and Pakistan, one has to put the dimension of what the security forces do and what is the full dimension of the program. Clearly, for vaccinators to be able to get out, some level of security and protection has to be provided. But I think it quickly stops there. I think what is really, really important is that who are the vaccinators and how are they engaging with the communities. And so in large parts of Borno now, they are not going alone with polio vaccine. They are taking MCH services. They are also now applying a tactic that worked quite well in southern Afghanistan, which they call the permanent health teams. So they take respected individuals from the community, train them, give them the vaccines and medicines, and have them go around on a rolling basis to provide vaccination and medicines to their own community on a rolling basis. So they identify these linkages called permanent health teams that live in those communities to do that. So these are the other dimensions of the program that you actually don't see in newsprint, because it is also very difficult for vaccinators to go out in such an insecure environment, because they become targets themselves if you don't take those community engagement measures. So what I'm trying to say is that this is not anymore, not because we are super intelligent or anything. It is the imperative of the program. If we want to vaccinate people in an insecure area, the first step is we have to have support of those people for us. Otherwise, these vaccinators are a target, and we cannot operate in that environment. Thank you.
The question is this polio eradication campaign, this is really avant-garde means for an arrière-garde fight, and this avant-garde means could really be used by other public health issues which have been overlooked so far. So I don't think that this is MSF's official position on the question, but by opening this discussion, we wanted to authorize ourselves to challenge and question a certain number of things which are presented in the program. So I hope that at least we've reached this objective, and I will leave the last word to our colleagues from WHO. And once again, thank you for coming, and thank you for your conclusion.
I would thank you for inviting us to this discussion, and I have to say that it's been a very rich and frank discussion, and really a diversity of perspectives, which is always very good. So thank you for convening this. I would just conclude by saying a couple of things, in response to the recent questions, which you also said were sort of the concluding statement. In Pakistan, while there is tremendous international pressure, there is tremendous internal pressure also on the government to succeed in polio eradication. Because, as I mentioned, that internal pressure on the government to succeed, they've been at it since 1994. So it's a huge internal embarrassment for the government also, because it challenges the government's ability to accomplish something within their own borders. So I think, and Nigeria is not too far behind in this regard. So I don't think we should leave the room thinking that these countries are only struggling because there is external international pressure on them to do this. Secondly, I think the environments in which the violence is happening, and the question being raised that how much of the human cost should we tolerate in polio eradication, I think it is too simplistic to think that the violence we are seeing is because of polio. This is not related to polio eradication. This violence will continue if you stop the polio program today. This is not about polio eradication. I think we should be absolutely clear about that in Pakistan and in Nigeria. This is a much bigger political issue
because polio eradication is an international program, because it has high visibility, it is being used as a political tool. You take it away, there will be another tool that would be used in the social sector. So I think it's very simplistic to think that this is related to polio. We should be very clear about that. Thirdly, I think clearly the polio program has to continue to learn the adaptation, the social and political adaptation that it has to take to ensure complete community trust and buy-in in the program, because without that, we know that we will not succeed in these final pockets. So thank you.
Thank you very much. Elisha, you want to add a concluding remark?
Thank you very much. You know, Dr. Jafari and I don't quite see eye to eye on these issues, but I hope that they're successful. I mean, I hope that we're able to stop transmission of polio. I don't have a problem with that. So we'll see what happens.
I didn't disagree with anything you said. So.
Oui, non, Hamid a tout dit. Juste quand même une petite remarque.
Yes, Hamid said it all, but just a small remark, concluding that because we didn't stop the program on the basis of the killings, well, I wouldn't want you to reach that hasty conclusion. Maybe René Broman has a philosophical interpretation for this, but it was a bit hasty. Anyway, thank you so much for inviting me, and it was worth it getting up at 4 o'clock in the morning. I don't want to make you feel guilty, but it was all worth it.